So let's get into our IHI video.
In this series on leadership roles and practices to support teams through COVID-19 as it pertains to psychological safety and well-being. And today's session will specifically focus on the regulated adult and the importance of self-care for maintaining team stability. My name is Sarah Sjostrom. I serve as the Associate Chief Nursing Officer at Hebrew Rehabilitation Center, and I'll be walking you through Module 1 today. As we begin the conversation about care for the individual and care for our teams, it is vital that we first begin to shift our perspective to recognize that these are not niceties or luxuries, but providing care for individuals and for ourselves as leaders is in fact a necessity. And in reference to, of course, Maslow's hierarchy of needs, which I'm sure many are familiar with, it lays it out plain and simple. Our need for food and water, taking breaks for rest, feeling safe and secure in a controlled environment, these are basic human needs. Our need for connection, our need to feel competent and capable, these are basic psychological needs. So when we talk about ways that we can support this for us as leaders and for individuals, it is important that we recognize that these are essential to our function and will impact the function of our teams. So we need to start with that perspective shift and then also recognize that this can happen in small doses and small changes, not everything at once. A little goes a long way. So as we've established, self-care and care for the individual is essential, not a nicety, but a necessity. And for leaders of teams, this becomes even more important to recognize that it needs to happen first. You cannot care for anyone without first caring for yourself. So akin to the messages we receive when we board an airplane, you must fit your own oxygen mask first. You must take care of yourself before others. And this can be a very hard concept, particularly for us in the caring professions, where there's a service before self mentality that often prohibits us from providing that great self-care. But again, we need to shift that perspective to recognize that this is not egocentric and not selfish. It is just really good advice, and it will better equip us to care for others. So what is that self-care and what does it look like? I like to think about self-care in two separate buckets. The first being, what are the things that you are going to say yes to? This is like what charges your battery, what gives you energy, what makes you feel good and revived. And that's going to look different for everybody. For some, that's going to be getting outdoors and being active. For others, it's just taking a rest and taking a nap. For others, it may be going out to dinner, being social. Again, it's going to look different, but it is whatever is going to give you energy and charge your battery. Equally as important to saying yes is recognizing what are you going to say no to. And this is a very important concept of saying no and being able to set boundaries and set limits. So this can be physically taking a step back or removing yourself from situations. It can be saying no to taking on more work, setting boundaries in relationships, disconnecting from social media, and knowing when to ask for help. And another huge one, and not one to be overlooked, is being able to let go. And this, again, can be very hard for folks in caring professions. But it's important that you come to a point where you can recognize that you have given your all and done your best. And sometimes that requires even physically using an affirmation and telling yourself, I've given my all today. I've done all I can do with this. And then you need to move forward. So in recognizing that caring for ourselves, we need to say yes to what charges our battery and also be able to say no to the things that drain our battery. An important and interesting concept when it comes to emotional dynamics of individuals and teams is the idea of emotion contagion theory. And it's important for leaders to recognize that individuals don't function as emotional islands. As social beings, we want to converge emotionally, and we have a tendency to mimic each other's dynamic. And we can see this on teams where there's low morale or high morale, that team members feed off each other. The impact of that emotion contagion can be very big. It can only take one individual who's not caring for themselves, who's not feeling at their best, who has that negative mood. And that can very quickly, that one person in the red who's not doing well, can very quickly spread that dynamic to their other team members. And this is the theory and research behind emotion contagion, that we as individuals have the capability to catch the emotions of those around us. And that becomes true of both positive and negative emotions. Now we begin to consider how everything we've talked about to present, self-care and care for the individual, and the emotion contagion theory, how these come together to paint a picture for the role of the leader in managing the overall team mood and dynamic and the overall team morale. So first and foremost, as we discussed, the leader needs to fit their own oxygen mask first and self-regulate first. As the most influential member of the team, having a cool, calm, collected leader who's self-regulated per emotion contagion theory will help to manage and stabilize the mood on the team. Being present for the team, being there, demonstrating that regulated individual, modeling that self-care, letting the team know that that care for the individual is indeed a necessity and not a nicety, and helping team members to engage in that behavior themselves. As the leader, you have the ability to give permission to your team members to provide self-care. Normalize conversations about stress, emotions, and trauma. Let people know that these are tough times and that we are all reacting in very normal ways to a very abnormal last year through this COVID-19 pandemic. The more that we're able to talk about the emotions, the more that we make team members feel comfortable that they're okay not to be okay, they're okay to seek help, and it's okay to pause to care for ourselves in such challenging times. And finally, the leader can take a huge role in neutralizing the negative emotions of team members. And that doesn't mean telling team members that it's okay not to have a bad day, it's okay not to be okay. It means that you're going to step in and intervene when necessary to prevent that emotion contagion, to prevent that negative mood from spreading, and to not allow for behaviors that undermine the team, such as backstabbing and bullying. Thank you so much for joining us in Module 1. We look forward to seeing you again in Module 2.
Great. Yeah. So I think some very sage advice there. A lot of things that are common sense. I just put in the chat box. I like the referral to reduction in social media time. You know, you always get those on your iPhones or Androids, you know, that tell you you've either increased or reduced your screen time by X number of hours or minutes. So I'm thinking like maybe that could be a contest or something amongst the staff, you know, to see who's got the best commitment to reducing, you know, their phone time. And then the other point that I made in the chat box was that from our last couple of presentations ago, there was data that showed that staff who do 2 or more double shifts per week have a very high incidence of burnout and low energy. So, you know, in the medical training field, so when we train medical residents in internal medicine or family practice, we have to monitor the number of hours that they do, and they can't do more than 60 hours per week, which, you know, that's a lot. But they have to have minimum of 1 day off per week. That's part of the guidelines to you know, reduce burnout. And it states how many so they can only have 1 double shift per week. They can't have 2. So there are some structured policies that are in place even with medical training, and that's a far cry from the days that I did my medical training where I was on every, second or third night. So we were doing, pretty long hour shifts. And I can assure you that myself and everybody else got burnt out pretty quickly. All right. So let's talk a little bit about the older adults and falls. So this is going to be more sharing of our process of the QAPI amongst the facility. So again, we're asking you to, if you can, to get some homework done, such as a root cause analysis for falls, so that we can share that and discuss it and refine it. And then a lot of these elements, quite honestly, are shareable, right? So we want to share these so you don't have to reinvent the wheel. And then they count as part of your, if you get audited, you say, well, show me your QAPI on falls. Here it is. It's been done. So that's our intention, is to really get this all integrated into your quality improvement programs. Okay, so let's go. Do we have next slide there? Yeah. So Michelle, do you want to take over for this one?
It's actually Kelly.
Kelly, I'm sorry. Okay, yeah. Kelly.
And April.
And April.
That's April.
Yeah, April was kind enough to visit with me earlier this week about her, or I guess last week, about her root cause analysis. And I am going to turn it over to her and kind of let her talk through what they determined whenever they did this activity.
So this is our brainstorming session, and we just wrote down pretty much anything we could think of for any reason why anyone fell ever and put it all down on paper. And then we pulled out a few things that we thought that we could actually collect as, and see if we can change some things. So there were a few things that stood out to us, the care planning and the charting, and then the fall huddle and the alert system. So our facility has an alert system where the nurse can send a message and it'll show up at the top of the iPads for all the CNA staff, and it'll tell them, so-and-so fell, and you can put a time limit on it and say you want it to show for 24 hours or 72 hours or whatever. So our staff, some of them are really good about using the alert system and sending an alert with, different things. And it's not just falls, it's, push fluids on this person for this and do this for that. But, and other people don't use it at all. So we're just going to collect some data on, was a fall huddle done? Was the fall huddle tool used? Was an alert sent? Was the fall charting complete? And then was the care plan updated? And so we decided to start collecting this data on our unit that has the most falls, which is our Alzheimer's unit, our locked unit. And the nurses started using it. And I don't know if you have my other tool up there, but it's when you see a resident who has fallen, do the following. And it's, a few questions like ask the resident this, this, and this. And then we also had them filling out this false PIP tool. And we ended up having to how to do the PIP basically. And we actually had to have them we had to write up directions on what a fall huddle is. So one of my problems as a leader is assuming that people know what I'm thinking. And when I say fall huddle, I assume that they know what a fall huddle is, but they don't. And they don't know who should go, and they don't know what they should talk about, and they all just kind of stare at each other in a circle. So we've had to develop other things. And I mean, we just sent this out when did we start this? Last Friday? So in like 4 days, we've already figured out that they don't know A, B, C, D, and E. So we have to really start from the beginning on this. And so anyway, that's one of my biggest challenges as a leader, is that I just think people know things and they don't know. So we are in the process of explaining to the staff, what we're trying to accomplish and what a fall huddle is and who should go to the fall huddle. We didn't realize how far away from this we've gotten. And so, yeah, that's where we're at. We've had probably 5 falls so far. And then the nurse collects the data because, I mean, we won't know if she does a fall huddle or he, unless they mark that they did a fall huddle. But we can tell in the charting, you know, what was discussed in the fall huddle and if it was helpful or not. Because some people will just write things like, one of the questions is, what did the resident see before the fall? And you have some people that explain that the resident thought they saw someone walk down the hall, and, you know, it's really great charting and it's wonderful. And then you have other people's chart that they saw the floor. Well, okay. It wasn't meant to be, you know, verbatim. It's like, so that's where we're at. I mean, and yeah, we'll keep collecting.
April, I think you guys have done a great job, and I want to commend you for how many details you put on your fishbone diagram when you all did it as a team, because I think it's important to put as many things out there, and then you kind of track and trend, figure out what has a common thread or a common theme to focus your attention on. And that's what you guys have done with this huddle tool to make sure the staff know it. But another piece I want to acknowledge is that you're just doing it on your Alzheimer's unit. And doing it in that small area, testing that change. And I think that allows you the opportunity to really see those points of charting, for instance, that they just wrote to floor. You're really able to identify it because you're not evaluating every single one that closely. You're just doing it in that small section. So then at that point, as you monitor for so long, you may pick up a couple of those things, and then you can continue to educate your staff as you push this through other areas of the facility on this is specifically what it could look like. And you could even provide an example, you know, this is how you respond to these, this fall huddle, like do an example incident report with the huddle documentation or the charting so they can understand what your thought process is. And yes, from my experience, I kind of think I'm on the same page with you, April. I would always assume people would understand what I was talking about too. And unfortunately, that's not the case, but we don't really know that until we put something in place and test it. So kudos to you guys. I think you are on the right path, and I look forward to seeing the improvement on that unit.
Yeah, thank you. Thank you. Yeah, we're starting from scratch. So, and we've been doing fall QAPI for a while. We just didn't realize, you know, with the pandemic and everything, we've shifted to infection control and we've gotten away from like literally everything else. So we need to go back to the drawing board, and we've had a turnover in staff, you know, probably at least half the staff has turned over in the last 2 years. So. Yeah,
I think that's an excellent point, you know, because you're kind of, you know, having to reload the gun, you know, with these turnovers. And I think that that's just a really critical point, is that as you come back to these elements of quality improvement, you know, I've heard it before, you know, the redundancy is so important. I can't stress that enough. It took me 6 months when I first got involved with the Institute for Healthcare Improvement to just start to absorb and understand this whole process, and then it took another year, quite honestly, before it became, you know, what I would call second nature, where I was very comfortable saying, yeah, we're going to do a plan, do, study, act cycle, which, by the way, I've applied to our educational programs. So all of our educational programs are in these plan, do, study, act cycles. You know, we try to figure out a problem. Can we, you know, solve that problem by a little different approach here. The other thing that I wanted to mention is part of that expansiveness of your root cause analysis. That I agree with Kelly. That's really pretty extraordinary. You covered a lot of bases there. Hopefully through these sessions, that list may even get bigger as we get a little bit more, how do I want to say, expanded view of the etiologies of falls. And so I did a quick view there, and I wasn't quite sure whether I saw whether any of the falls were linked to time of eating, for example. What did the fall occur within an hour of eating? Did the fall occur within a week of hospital discharge, you know, a return to the facility? Was the resident wearing glasses at the time. So some of these things that, as we know what the risk factors are for falls, those are 3 examples that I just gave you. They then become almost second nature as part of your huddle and evaluation. The other thing that what would be good is to just simply ask the question in the huddle, is this a recurrent fall? Is this a frequent faller? A frequent flyer, frequent faller? And probably everybody will say yes. And then, if they were a frequent faller, and then the next question becomes, well, what was the cause of the fall last time? And so then that becomes a whole issue of, insight for the CNA, whether they read the notes, for what the workup was, and then some just other questions. Did anybody think that the fall was related to a new COVID infection, right? Because fall, we talked about atypical manifestation, and I know people fall a lot, but it technically should be a moment of testing for COVID, because falls are associated with as an atypical presentation. So there's a lot of spin-offs from this, and just who's ever handwriting? Is that it? Your handwriting, April?
Oh yeah, that's my handwriting.
Okay, well you did well in school. I think your penmanship is remarkable there. Maybe it's because I'm left-handed that I notice those things, because I write kind of in doctor scribble, so it doesn't always look good. So that looks nice. It's very readable and very authentic. So thank you, Kelly and Jean or Michelle. Do you have any other additional comments that you want to make about the?
April, I'm not sure if you had a date on that root cause analysis, but I would recommend y'all put a date on it. And then each month when you're putting it through QAPI, look at all of those bones again and see if any of them can be marked off. Like, you know what, we've been doing this so well now, I don't believe this is a reason for a fall anymore. And I think that is a good visual for your staff to see, hey, we recognize this is a problem, we put something in place, we monitor it, it's no longer on here. And then if you, as you're moving forward and monitoring this on a monthly basis, if you see a spike again or something like that, then you can look at this same root cause analysis and the same fishbone diagram and try to trend some other areas that may be an issue. But I would definitely keep that on hand, and you can utilize it in the future.
Yeah, and I think I think April sort of alluded to the issue about this is a post-fall assessment as opposed to a proactive fall prevention approach. So we need to break down your quality improvement into 2 elements. One is post-fall resident-specific interventions, and then there's the more global fall prevention program. So you say, well, which one's having the impact on fall reduction, if any? You won't know. I mean, but you have to do both, and it's multifactorial, and that's the way quality improvement works. You do multiple tests at the same time, and try to identify if you're moving the needle or not. The other thing I was going to ask, have you shared this with the CNAs? Have they?
Sorry, let me unmute. Well, it's a one-on-one kind of thing, I think. We are going to have a CNA meeting coming up here, but it's almost like you need to sit down with each one of them and tell them exactly what to do. If you try to send it as an email, or we see this problem happening, they either don't read it or they just delete it, or it's just, it has to be education from the nurse to the CNA at the time. And so we need to reach the nurses on that level first. So we do have a nurse meeting scheduled in July coming up here. And we're going to have an RN from the University of Mary come in and discuss charting and the legality issues with their charting, and how would they defend themselves in court with the charting that they have, because it's so poor, so yeah. 6 months from now, how are you going to sit on the stand and and tell someone what happened in this fall when all you wrote was, you know, that they saw the floor. So it's like, it starts with the nurses, and then it has to trickle down to the CNAs, and the nurses need to do that education, you know, but we got to give them, we have to give the nurses that education first, and we have to give the nurses the encouragement, I think, to be that teacher and that leader. We have a lot of really shy staff, so I don't think they communicate very well to each other. I think communication skills are at an all-time low, actually. So, you know, that's part of the problem too.
I think this may be too harsh of a term, but fear is a motivator. And for those nurses to understand, you're not only doing this charting so the communication can be clear, so you prevent falls for the resident and the resident safety, but look at what your responsibilities are as a nurse and how it's going to affect you personally. I think people have to see both sides of it. How is it going to affect the people you're taking care of, as well as how is it going to affect you personally? And then they get much more of an eye opener.
Yep.
Yeah, that's a really good point. And that's true in healthcare in general. It's not until the patient sees how it's going to affect them or have, you know, some impact on them that they then get the buy-in. So, you know, that's why a lot of times we have open-ended questioning, you know, during a clinic visit. You know, we'll say, well, what's most important to you? And then they have a thing called the target. I think I presented this before, where there's a target, and then they align, you know, towards the center of the target, their most important issue to them of many, you know, problems that they have. But I think, April, you're really hitting another nail on the head here with the identification of communication, right? So you haven't really quantitated, you know, the communication gaps. And I don't know if our QI experts here have any tools that they know about for measuring communication, but that's really on the top of the list, is to improve those communications. So part of the, how do I want to say, the staffing, you know, concerns that we're talking about get tied into, you know, the communications, and I don't know. I mean, I see that failure of communication occur. I mean, it certainly occurred in the clinic that I work at, you know, where 25% of the staff, you know, are moving on to other jobs. There was really very little communication going on during the year, you know, and in part because everybody was assigned to, you know, the COVID surge, for example. I mean, I was the only primary care doctor in the clinic while everybody else was assigned to the hospital. You know, so there was just that lack of communication going on. And interestingly, we tried to use a, what do they call it? Snapchat or whatever, WhatsApp. That's what it was. And well, for a while we were using that. We're communicating some issues about best practices, what's going on in the hospital. So it was kind of a sharing of issues, and you know, that might be a technique for for some of you to consider, you know, using a group chat to improve communication. You can and again, test it out, see if it works. We tested ours out, and as the pandemic surge declined, we thought it wasn't quite as valuable as it was during the the uptick. So I don't know if you have any thoughts about that, Kelly or Michelle, Jean.
Well, actually, the work that I did with Cheyenne Crossings, or not Cheyenne Crossings, Sharon Care Center, the communication aspect was one of the areas that we decided to focus, or that they are already focusing on. So coincidentally, if we want to go on to the next fishbone, and while we're doing that too, I would love to see in chat if from any of the rest of the folks participating today, if how do you feel about your staff with their understanding of what a falls huddle is? I think this was such a revelation that April came up with, that the team doesn't even know the rudimentary part of what we're talking about. So, just have you guys thought back that far? Have you dug down in your whys even that far back? So this is Fishbone from Cheyenne Care Center. We have Amanda Morlock and Rhonda Shell with us today. I just pulled out some of the documentation that they had pulled together on a different format and just put it in our Fishbone because that's what we were using more. I do want to just point out that just the major bones where it says residents, equipment, staff, where it says communication, it actually before said facility. And we didn't really, when we came up with these topic areas, I was meeting with Jean and she and I decided, you know, this isn't really facility. These are all communication kinds of things. But this is all the work that actually they had already done. And I just put it in the format and I circled the ones that Amanda told me what she was already looking at working on. And so Amanda, if you're there and willing to share, I'd love to have you just go through how you decided that these were your main areas.
Yep. So I monitor the falls every month, and upon looking at those, I've also been kind of watching people that have gone to the hospital or that are on antibiotics as well. And I noticed a trend that a change in status, someone that would end up going to the hospital, coming back from the hospital, or that was on an antibiotic for, like, say, a UTI, were our main fallers during the month. So we've been looking at implementing more tracking of the change in status. We did do education at our last nurses meeting regarding using that eInteract change in condition assessment. And we have been trying to get the staff to use the Interact stop and watch tool more often as well.
We also worked with the staff in regards to when, giving a report, to have thorough reports so they're aware of who has just come back or who has had frequent falls, who's on an antibiotic in report, so that the CNAs are aware of that and they're understanding. It's important to make sure that you're working closely with them, paying closer attention to them because they have had a change in status. So that's part of the communication. We do have we found a lack in our rounding from CNAs to CNAs. So we're working on that part with the communication.
And so do you have an actual document that you use for rounding so that they have a specific things that they're covering, or do they just have their own list of things that they discuss back and forth? Or do you know?
No, we have a rounding sheet, things that they're supposed to go over and make sure that things are in place, and what they, change of condition is one, are they new, things like that. So we do have that in place. Okay. Mm-hmm. Is it being used all the time? We come across, no, not always. We struggle with staffing, issues like everybody does. And we pull from different areas because our facility is so large that sometimes we have to pull from floor to floor, that rounding has a tendency to get missed, or we might realize that we're short on one floor and we need to pull from another floor, so they don't always get to participate in report. So those are some key things that we have to look at.
And I would argue that, even the report between CNA to CNA on that kind of a walk rounds kind of thing where they go around, that's probably even more important than getting the report from the nurse. Mm-hmm. And
sometimes that doesn't happen, like what happens is so everybody's supposed to come to work, and then we realize that we have to pull somebody because somebody is short, and they don't realize it right away. And then the next shift probably has already left. Sometimes it happens. So when that person is pulled down from the other areas, the person that was they should round with has probably left. We've run into situations like that. So we have a few issues there that we have to work on with that, the rounding.
Yeah, that's perfect. And so as you identify that as a problem, that then becomes a plan, do, study, act cycle. So if you can say, 60% of the handoffs or the huddles where the handoffs did not occur. So then you put something in place and see if you can get that down to maybe 30%. So that's a plan, do, study, act cycle that would address that the handoffs, which, by the way, is in the medical literature. That's a very common problem of you know, and it's a huge problem for hospitals, you know, as to how the handoffs occur. So it's at all levels of the healthcare system. I was going to add, we're kind of getting close to the hour here, but the book that I was telling you about has some comments about communication, and they were addressing one of the comments that we made earlier, which was how to deal with the you know, the less vociferous person. You know, so they say don't let anybody dominate the conversation in the huddle, and so one of the techniques would be to pass a stick or a staff, you know, like the talking stick. So, you know, if somebody says something, then they pass it on to the next person. So the expectation is that everybody's going to contribute. This is wonderful. Michelle and Kelly, do you want to have any wrap-up comments?
I just wanted to add, Cheyenne, when I talked with these guys, they're not ringing their own bell near as much. I mean, they had done so much work already and had actually looked at all those things that Rosewood had talked about the week before. They had looked at, you know, time of day and what shift it was and who was working where. And that's really where they came up with that shift change as being where falls had increased. They had done some really great root cause analysis that it doesn't all reflect exactly in this fishbone, but they have done a lot of great work. So
yeah, I would encourage thinking about our facility partners here. If you got a couple of superstar nurse and CNAs that have got this down for the huddle, we could do a simulation or a mock huddle as one of our presentations, and you know, invite some additional staff members from our affiliate facilities here and observe, you know, what a well-greased, you know, well-honed huddle might look like. And the reason I'm saying that is that you know, there's a psychological thing that if you see something done well, you're more likely to replicate it than if you see something done poorly. And this is certainly true in baseball psychology. They found that when they try to increase the number of home runs or a hitting percentage, when they showed the baseball player what he did right to hit the ball as opposed to what he did wrong, it was the former, the positive reinforcement, that really elevated their game. So too, maybe we can do that with the huddle looking forward. Any other thoughts or comments from anybody?
Yeah, I just want to say I think it's a great job, and at the end of the day, I feel like communication is always key for your improvement in the facility. Everyone gets in the hustle and bustle and busy, and feel like, oh, I can skip that step because I've got too much to do on my checklist. But really, it's going to save you time in the end whenever you're communicating those details.
Yeah, and I think, you know, and we find this on medical rounds, right? I have medical students who tend to be quiet, and so what I do is I put my hand out to them and I said, Jim, what do you think? And, you know, they may kind of do a few gulps and, you know, get a little foot tapping going on there, but eventually you can pull them in and it works. So you have to be very active in your leadership and invite people. And like I say, it's not pointing at them, but rather putting your hand out as a gesture of, please, you know, let me know what you think. We value what you have to say and what you're thinking.